Assalamu alaikum, ladies and gentlemen, and thank you so much for inviting me for this really important presentation. I'm so happy that the neonatology group has chosen neonatal nutrition as the theme for this year's neo-colloquium. Now, I just want to I have no disclosures to make. The objectives of this talk would be for me to review the latest evidence-based information on practices related to enteral nutrition in neonates, and also hopefully this should help our young and budding neonatologists and pediatricians to evolve guidelines that are best suited to local circumstances. So the first question, what is enteral feeding? Enteral feeding is best described as a form of nutrition that is delivered into the digestive system as a liquid. And you know that this is something which is not confined to the neonatal age group, but we also see enteral nutrition being given in adults. Strictly speaking, I suppose oral feeding would be enteral nutrition because that's nutrition being given directly into the GI tract. But when we talk of hospital-based nutrition, we don't include suck feed or oral feed. Usually what we mean by enteral nutrition is liquid nutrition being given through some form of a tube directly into the GIT, usually bypassing the oral cavity. Now, we all know that neonatal period is characterized by it's a period of rapid growth and development, which leads to major requirements for energy and nutrients. At the same time, it is associated with immaturity of GI and other associated organs. And therefore, nutrition in a newborn, particularly a hospitalized newborn, is a bit of a challenge. This challenge is even greater in a preterm baby, because imagine a baby being delivered at 28 weeks of gestation. We know that maximum accretion of fats and macronutrients takes place in the last trimester. And the rate of growth is almost fourfold higher in the last trimester than the earlier periods of gestation. And if you have a baby who's born at 28 weeks, not only is the requirement very high, but also the immaturity of the gut and associated organs that I spoke of is even higher. So these babies are very, very prone to growth failure. And growth failure, remember, does not have short-term outcomes. It also has long-term outcomes that extend well into the adult life of the individual. So you can have individuals who have impaired neurocognitive outcomes. They're doing poorly at school. They will not do so well in their occupations. And also they carry an increased risk of cardiovascular diseases and insulin resistance. So many metabolic disorders will have their origin in the neonatal period. So this is just a graph to elucidate the point that I was making. Is if you see that maximum period of growth is after the 28 weeks, where a lot of macronutrients are being deposited in the body of the preterm. And this is the sort of growth that we need to translate if the baby is delivered too early. So again, this table is just for comparison. I mean, I don't expect you to remember the exact values, but as you can see that the energy, protein, fat, carbohydrate, calcium and phosphorus requirement, amongst other micronutrients, is about 20 to 50-fold higher in the preterm than in a term baby. And the more preterm you are, the greater your requirement will be. So neonatal nutrition has been a gap in our nurseries. It's been, if I look back on the time that I worked in various neonatal units in the country, we have neglected nutrition, and it's not entirely been our fault because there's been so much emphasis on survival that we've often forgotten to fine-tune nutrition. Also, there's been a lack of nursing staff. We still face a lack of nursing staff. There's been a lack of expertise in neonatal parenteral nutrition, and care of long lines and the high risk of line sepsis is something which still plagues us. So the challenge and the solution for us is to develop strategies in early initiation and rapid progression of enteral nutrition using breast milk in order to optimize nutrition. And keeping in mind, whenever you're dealing with a newborn, all neonatologists, all pediatricians, keep in mind that growth restriction and suboptimal neonatal nutrition have been identified as risk factors for adverse long-term outcome. So we should not be looking just at survival of newborn that we have done over the past several decades, and I don't blame anyone, we have been short of resources, but we also now need to look at event-free survival, so a preterm or a newborn surviving with minimal disabilities. When we talk of nutrition, then we need to have certain goals in mind, and I like to see 4 goals of nutritional management. So the first one is to meet recognized nutritional requirements, to try and achieve an acceptable standard of short-term growth, at the same time to get along with it and take care to prevent feed-related mortalities, especially necrotizing enterocolitis, and also to optimize long-term outcomes. The first question when we talk of enteral nutrition is what feed to give, and without any doubt, mother's own milk is the best choice. But we also have other choices if mother's milk is not available, and that's donor human or breast milk, which is probably the second best option, followed by fortified human milk, followed by formula milk. Now, the literature abounds with the benefits of mother's own milk or freshly expressed mother's own milk. It's a preferred source of nutrition for both preterm and term infants, and particularly so for preterm infants. It's associated with numerous short and long-term outcomes like protection against infective processes like necrotizing enterocolitis, late onset sepsis, bronchopulmonary dysplasias, and there are long-term studies looking at long-term outcomes like neurodevelopment, and breastfed babies are associated with better school performance, higher IQs and higher EQs. It prevents against oxidation injury, particularly retinopathy of prematurity, is associated with improved bone health, so lesser chance of rickets of prematurity. And also, as I said, the benefits spill over in adult life. So adults who have been breastfed as babies have a low risk of hypertension and atherosclerosis later on in life. They also seem to have better systolic and diastolic function. So a lot of cardiovascular benefits that kind of spill over in the adult life. And this is just a systematic review which looked at 44 studies, and this is post-1990 literature, and it looked at babies born at less than 28 weeks of gestation and less than 1,500 grams of weight. And the authors concluded that human milk provides a clear protective effect against necrotizing enterocolitis with an approximately 4% reduction in incidence. And the authors also noted that it provided a possible reduction in late onset sepsis and severe retinopathy of prematurity and severe necrotizing enterocolitis. And they also noted that for NEC, it was true that so if you're doing mixed feeding, then any volume of human milk is better than exclusive preterm formula. And the higher the dose of human milk, the higher the protective effect. Again, as I said, if for whatever reason, every effort should be made to obtain freshly expressed mother's milk. But if for any reason it is not available, then the next best option is donor human breast milk. Now, we have a history of actually wet nursing, and the Prophet ﷺ, we all know, actually had a wet nurse. But this is a practice which has not really caught on, and I don't think we have any breast milk banks in the country. Even abroad, they are far and few. Nonetheless, the concept of supplementing or substituting mother's own milk where it is not available with the donor human breast milk is there, and I think it's something that we need to look into. Well-organized breast milk banks will use pasteurized human milk, which has undergone the process of pasteurization using a pasteurizer. It's usually screened for HIV, hepatitis C virus, and hepatitis B surface antigen venereal diseases and bacterial infection. And donor moms are also screened for the same diseases within the 6-month period. So if there's a mother who wants to donate breast milk and has not been screened in the past 6 months, so she'll undergo all this screening. Donor human milk can be stored, and the milk banks will store it at a temperature of minus 20 degrees centigrade, where it remains, is good to be used for a period of 6 months. Obviously, if you're using donor breast milk, it has to be with consent, which is particularly important in the Muslim society that we live in, because you people probably know more than me, this issue of razat and having breastfeeding from a woman has religious implications as well. Now, where human milk is not available, then formula milk would be the next choice. And formula milk is given depending on whether you're dealing with preterm baby or term baby. So you have separate formulas with separate caloric and micronutrient values for preterm babies versus term babies. And there are lots of studies that show that feeding preterm formula probably has a better outcome in terms of a baby's growth, but is associated with a higher risk of necrotizing enterocolitis. And then this is reference to another study which looked at almost 1,800 infants, where they compared infants receiving donor breast milk versus formula, and again the same results, although the growth was probably better with preterm formula, but the risk of necrotizing enterocolitis nearly doubled. Now, this is a bit of a theoretical discussion whether or not to fortify breast milk, and we'll come to it later on. So preterm infants, normally the breast milk will fail to meet all their nutritional requirements, and most units across the world are now recommending fortification of breast milk beyond a certain volume. Fortification can either be monocomponent, where you can fortify the expressed breast milk using proteins or fats or carbohydrates, or multi-component. Multi-component fortification yields better results than monocomponent, and many units have now a policy of fortifying expressed breast milk for all babies who are less than 32 weeks and less than 1,500 grams, and even for bigger babies if their growth is suboptimal. So again, the milk fortifiers may be human milk-based fortifiers or bovine milk-based fortifiers, and human milk-based fortifiers, for it's not a surprise, have better outcome in terms of lesser incidence of necrotizing enterocolitis, lesser morbidity and lesser mortality. And I think some time ago Nestle was providing human breast milk fortifier in Lahore, but I think it's no longer available. But it's good to keep in mind that fortification is needed because volumes higher than 180 or 200 ml per kg of expressed milk, breast milk, will probably not be tolerated. And if you want to go up on the nutrition, you can't always do that by increasing the volume. You'll have to do that by enriching the available breast milk. Again, you can have standard or individualized fortification, and standard fortification is where you dissolve a certain amount of fortifier into the expressed milk, and target or individualized fortification is to suit the needs of that particular individual. So you can have target fortification where the milk is analyzed to see if it has sufficient proteins or other macronutrients in it, and then fortified accordingly. Or you can have adjustable fortification where the baby can undergo tests. So for instance, you can follow up the serum albumin and urea levels and then give that monocomponent to suit the needs of the baby. Again, a reference to randomized controlled trials. So protein alone fortification has good short-term benefits, but probably no long-term benefits. Again, fat alone supplementations, short-term benefits, yes, but probably no long-term benefits. Multi-component breast milk fortifies, and as I've said, many guidelines, in fact, most neonatal units across the world do recommend adding this to the really preterm babies. Now, once you're fortifying the milk, it's really important to follow these babies up and do a growth monitoring. So best done on Fenton charts, but as a rough figure, the weight gain, which can be done daily or on alternate day, should be 18 to 30 grams per kg per day. The length and obviously the OFC would have to be done on the appropriate charts. The logical question is when to start. And the answer is as early as possible. So there's enough data to show that delaying enteral feed promotes inflammation, and inflammation that has a negative effect on linear growth and may accelerate the development of comorbidities like bronchopulmonary dysplasias and necrotizing enterocolitis. So contrary to what many of us have believed at some point in their careers, early feeding is, if anything, protective against early enteral feeding, if anything, is protective against necrotizing enterocolitis. Normally, the babies would be started on TPN. TPN is a bit of a gap in our neonatal units, and even abroad where there are facilities for total parenteral nutrition, the focus now is to introduce enteral feeding as early as possible to minimize the metabolic complications of parenteral nutrition. And if you can't feed a baby, if you can't give enteral nutrition, then, give oral colostrum. Again, lots of studies to show that just applying colostrum on the buccal mucosa of the baby is associated with increased absorption of secretory IgA and lactoferrin, and probably has some anti-inflammatory effect. And this entails just taking 0.1 to 0.2 mLs of freshly expressed colostrum and applying it on the gums and oral mucosa. It is associated with enhanced relationship between oral stimulation and nutrition. If you can't give full feeds, by all means, go ahead and give trophic feeds. Now, what is trophic feeds? It is feeding at rates at the maximum rate of 1 ml per kg per hour. It has no nutritional value. But as the name suggests, it prepares the gut, it stimulates peristalsis, it has immune modulatory effects, improves the tight junctions on the gut mucosa, and promotes the growth and maturation of gut mucosa. And it may be started on even the most preterm, the most IUGR, and babies who have a lot of comorbidities, like abnormal antenatal Dopplers, they are on ibuprofen therapy, have PDA, or are at high risk. So trophic feed is very, very safe, no nutritive value, but prepares the gut for enhanced enteral nutrition. So how do you advance on enteral feeds? Again, the more preterm the baby, the more risk factor a baby has, the slower you should go. However, again, there are studies that show that rapid advancement of enteral feed does not increase the risk of necrotizing enterocolitis, even in babies who are very high risk. And I've given a list of what I mean by high risk babies, or what the literature means by high risk babies. So very preterm, HIE, small for gestational age, absent and diastolic flow, infants who have UACs, who are hypotensive, who have severe IUGR, and so on and so forth. Even these babies can be very safely started on trophic feeds with rapid advancement. Again, this is a meta-analysis which shows that slow rate results in several days of delay in establishing full enteral feeds and may actually increase the risk of invasive infection. Again, what should be the interval between feeds? Now, a short too early interval would have the theoretical risk of less gastroesophageal reflux, while a 3 hourly interval would be associated with better gastric emptying. However, again, the literature suggests that there is no clinical difference between 2 and 3 hourly feeds. And this is particularly pertinent for our neonatal units, where we do not have the benefit of one nurse and one patient. So, by all means, give babies 3 hourly feeds, no problems. Again, the next question would be, this is a Cochrane review, which concludes that, looked at short versus long feeding interval, and they found out that essentially there was no difference, certainly no increased risk of necrotizing enterocolitis if you were giving larger feeds at longer intervals. So most units would have this kind of guidelines where for high risk they'll start with 12 to 24 ml per kg per day, increase by 20 to 30 ml per kg per day. They would keep an interval of 1 to 2 hours, but as I said, we need to keep our own neonatal units and our own resources, particularly the nursing staff, in mind. Intermediate risk can start with higher volumes and advance even more quickly. And low risk can actually start anywhere between 36 to 60 or even 90 ml per kg per day on day 1. Withholding feeds, there's literature and there's evidence to show that it should not be done lightly. We withhold feeds at the drop of a hat, and it's supposed to have bad effects on the overall nutrition. So only if there's very clear-cut indication should feeds be withheld. Routine aspiration is not recommended. Many nurseries will still routinely aspirate gastric contents to see whether next feed can be given or not. This can actually have harmful effects and damage the gastric mucosa. And remember, small quantities of bile may be found in the gastric residues, and many units will have this kind of a color chart. So up till here is okay, onwards investigate. Any undigested milk that is aspirated, if you're looking at gastric residues, should be refed to the infant. Otherwise, you lose useful nutrition. Obviously, in high-risk babies, look for signs of intolerance, which would be 2 or more moderate vomits, abdominal distension, or heavily bile-stained gastric residues. More clear-cut signs of neck would include bilious or fresh blood-stained aspirates, visible bowel loops, and grossly bloody, watery, or abnormal stools, and clinically unstable or acute deterioration. So if you see these signs, by all means, you should stop the enteral feeding. But if you're unsure, you're not sure whether it is neck or not, then literature says don't cut back completely on the feed. So go ahead, give trophic feeds as far as possible if you're unsure of whether or not it is clear-cut necrotizing enterocolitis. Routes of enteral feeding, there's been a lot of discussion about transpyloric, where you use nasojejunal or nasoduodenal tubes, and literature shows that there's no advantage. So go ahead and use gastric tubes, which can either be nasogastric or orogastric. And we use nasogastric tubes. I favor nasogastric tubes in our nursery because I think they're more secure. But if you look at literature, orogastric is preferred because nasogastric can obstruct the nasal cavity, and you know newborns are obligate nose breathers, and increase airway resistance, increase incidence of central apnea, and increase incidence of central breathing. Again, how do you tube feed? Now, these are the different methods by which you can tube feed patients. In newborns, we usually use the first or the last. So continuous, where you are feeding over 24 hours, and this is done by using either gravity or some kind of a pump. A cyclical and intermittent is not used in newborn, and bolus feedings where you give shorter periods several times a day through push or gravity. Which one is better? There are pros and cons of both types. I personally would stick to bolus feeding because I think that A, we don't have as many pumps, B, we don't have nursing staff to actually vigilantly watch each baby for aspiration if on continuous feed. So bolus feeding is more physiological, they have better feed tolerance and weight gain. Human milk, remember, tends to adhere to the plastic tubing of the nasogastric tube. So these babies will actually receive less fat. Babies who are on continuous feeding will receive less fat than those who are on bolus feeding. Time taken to achieve full feed is the same whether you're bolus feeding or you're giving continuous feed. Bolus feeding is associated with greater protein and anabolism, and there's no significant difference in the incidence of necrotizing enterocolitis between the two methods. However, literature just does say that continuous feed is associated with lower behavioral stress, and bolus feeding may be associated with increase in pulmonary resistance and airflow, decrease in cerebral perfusion, and with respiratory instability. But as I said, we need to keep our own staffing levels and our own neonatal units in mind. And I would tend to tip in favor of bolus feeding rather than continuous feeding. Can the babies be fed while they are on ventilatory support? And yes, absolutely yes. So there's lots of literature that babies can receive enteral feed, whether they are being ventilated or they are on nasal CPAP. Again, should you push the bolus or should you use gravity? Insufficient evidence to indicate whether one is better than the other. So, your video chalegi? Video chalegi? Okay. So this is gravity feeding, where you don't use a plunger, you just hold the tube and the syringe with a pre-measured volume, and you let it dribble down rather than push it down. But if you look at literature, there's no difference between the two. The gravity method will obviously take slightly longer, but this is probably safer. But look at your staffing levels. So it's not only the macronutrients that have to be kept in mind, but these babies also need supplements of vitamins and iron once they have established full feeds. Vitamins are usually started at 2 weeks and iron usually at 4 to 6 weeks. The question of probiotics, and there's always been a lot of confusion about whether to give probiotics or not, but now I think the evidence is more clear, and yes, probiotics have a beneficial effect in terms of protecting against necrotizing enterocolitis. And it's interesting that studies show that a combination of probiotics and a combination of probiotics and prebiotics is better at preventing necrotizing enterocolitis. So a combination of lactobacillus, Saccharomyces, and bifidobacterium. However, the evidence in extremely preterm infants and extremely low birth infants is lacking. If you have to start probiotics, most units would require informed consents from the parents. Remember, our job does not end with the discharge of the baby, but you also have to look at their post-discharge growth. And we don't have the luxury of a post-discharge formula, but you can have 3 types of formula. So preterm formula, which gives 24 kilocalories per ounce, a post-discharge or a bridging formula, which gives 22 kilocalories per ounce, and obviously the term formula is 20 kilocalories per ounce. 20 kilocalories per ounce is also the amount of calories in breast milk. If you fortify it, then the caloric value increases to 24 kilocalories per ounce. So see what your baby needs, whether, you have to optimize growth and you have any of these choices to make. I would just like to point out here that, instead of using, teats and nipples, there is some benefit of spoon feeding. It's something that requires greater expertise, but it is associated with lesser chance of necrotizing enterocolitis and also lesser nipple confusion. So mothers can successfully directly breastfeed and spoon feed, but if you're giving bottle feed and breastfeed, then the chances of success of breastfeeding decline because of what's called nipple confusion. So to end my talk, I'll just go over the few key points. Commence early enteral feed. Even if you have the facility of total parenteral nutrition, try and start trophic feeds with total parenteral nutrition, unless there's absolute contraindication, there's some kind of obstruction or something, and try to wean the baby off enteral nutrition as early as possible. And of course, breast milk is better than formula. Avoid discontinuing feeds unless absolutely indicated. Supplementing mother's own milk may be required if growth needs are not met. Probiotics may decrease the incidence of necrotizing enterocolitis. Spoon feeding is recommended. It's better than using a bottle with a nipple once infant is able to suck. And last, which is really important, practices with least milk handling are the safest practices. So, sometimes you may need to kind of be okay with suboptimal nutrition, provided that you're trying to minimize milk handling. I think that should be acceptable for our population.